Hello, we will be discussing infective endocarditis, which is done by Annika, Sabrina, Jocelyn, and Elizabeth. We will be discussing the definition of infective endocarditis and its etiology and clinical manifestations. We will also discuss the signs and symptoms, its diagnostic tests and treatment, as well as nursing, surgical management, and care coordination and transition management.
What is infective endocarditis? When we break it down, it simply means inflammation of the inner layer of the heart. Most often, endocarditis happens because of a microbial infection in the endocardium and usually involves the endocardial lining of the cardiac valves. Two of the most common bacteria that cause infective endocarditis are Streptococcus viridans and Staphylococcus aureus. The people who are at highest risk for developing this infection are males, patients with an open wound or abscess, someone who is going to have a dental or surgical procedure, intravenous drug users who are using infected needles, as well as patients with artificial or prosthetic heart valves. When we take a look at the etiology of infective endocarditis, the first step is that the endocardial valves are damaged. There are a number of ways in which this can happen, such as previous inflammation or injury. For example, in patients with a cardiac defect, blood may flow rapidly from areas of high pressure to an area of low pressure, causing erosion to occur in a particular section of the endocardium. This damage exposes the underlying layer of collagen and tissue factor in the endocardial lining and causes platelets and fibrin to adhere, forming a thrombus or blood clot. This low-pressure area serves as the perfect location for bacteria to gather together and multiply, forming a vegetative layer called a biofilm, which contributes to the destruction of the valve. Because the valves are now damaged, it leads to valvular insufficiency, which can happen when the normal alignment of the valve is affected. In some cases, vegetation becomes so large that the blood flow through the valve is obstructed and the valve becomes stenotic, increasing the chance of embolism in systemic circulation. A few of the clinical manifestations we see in an infective endocarditis would be a fever, Roth spots, ocellular nodes, a murmur, Janeway lesions, anemia, nail bed hemorrhage, as well as an emboli. An easy way to remember these manifestations is to note that they spell out from Jane.
Next, we will discuss the signs and symptoms. Most patients have recurrent fevers from 99 to 103 Fahrenheit. However, an older adult may not have these fevers. The severity of symptoms may depend on the virulence of the infecting organism. Petechia, which are pinpoint red spots on the skin, occur in many patients with endocarditis. Examine the mucous membranes, the palate, the conjunctiva, and the skin above the clavicles for small red flat lesions. Assess the distal third of the nail bed for splinter hemorrhages, which appear as black longitudinal lines or small red streaks. A defining sign for infective endocarditis is if the patient presents with ocellular nodes on their palms or soles of the feet, and if the patient has Janeway's lesions, which are flat, reddened maculae on the hands and feet. 4 systems will be highlighted. The first is neurologic system. About a third of the patients have neurologic changes. Emboli to the central nervous system can cause either transient ischemic attacks or a stroke. A patient may experience confusion, reduced concentration, aphasia, or dysphagia. The next is pulmonary system. So the other 2/3 present with this changes. Pleuritic chest pain, dyspnea, and cough are symptoms of pulmonary infarction related to embolization. The next system is the cardiovascular system. Assess the patient's cardiovascular status. Almost all patients with infective endocarditis develop murmurs. Carefully auscultate the pericardium, noting and documenting any new murmurs, usually regurgitant in nature or changes in the intensity or quality of an old murmur. An S3 or S4 sound may be heard. Heart failure is most common complication of infective endocarditis. Assessed for right-sided heart failure, as evidenced by peripheral edema, weight gain, and anorexia, and left-sided heart failure, as evidenced by fatigue, shortness of breath, and crackles on auscultation of breath sounds. Arterial embolization is a major complication in up to half of patients with infective endocarditis. Fragments of vegetation break loose and travel randomly through the circulation. When the left side of the heart is involved, vegetation fragments are carried to the spleen, kidneys, GI tract, brain, and extremities. When the right side of the heart is involved, the emboli enters the pulmonary circulation. The last system is the abdomen. Splenic infarction with sudden abdominal pain and radiation to the left shoulder can also occur. When performing an abdominal assessment, note rebound tenderness on palpation. The classic alteration in comfort described with renal infarction is flank pain that radiates to the groin and is accompanied by hematuria, which are red blood cells in the urine, or pyuria, which are white blood cells in the urine. Mesenteric emboli causes diffuse abdominal pain, often after eating, and abdominal distension.
In this slide, we will be discussing the diagnostic tests and treatments for infective endocarditis. So to begin, diagnostics tests that we could do would include blood cultures, an echocardiogram, and physical exam. On the blood cultures, we would expect to find some type of bacterial growth, indicating that we do have an infection, and the endocarditis would be evaluated with the echocardiogram, would give us a better idea of where the vegetations were, and also physical exam would lead us in the direction of chest pain. For treatments, obviously the go-to treatment would be antibiotics to combat the primary infection. And then also we can treat the symptoms. For instance, for the fever, we could give Tylenol or ibuprofen. For the dyspnea, we could administer some oxygen. And also, if there were any dysrhythmias that had developed, we could also give medications for those. So basically, we would just treat the underlying symptoms as well as the infection.
In this slide, it will be talking about the nursing management for infective endocarditis. So the nursing management of a patient with endocarditis usually includes antimicrobials, risk balance with activity, and supportive therapy for heart failure. If these interventions are successful, surgery is actually not needed. Like Jocelyn stated, antibiotics, specifically antimicrobials, are the major component of treatment. The choice of drug depends on what specific organism is involved. Since the vegetation surround and protect the offending microorganism, an appropriate drug must be given at a high dose to ensure the destruction. Antimicrobials are usually given through an IV, and the course usually lasts from 4 to 6 weeks. For most bacterial cases, the ideal antibiotic is one of the penicillins or the cephalosporins. So patients may be hospitalized for several days to start the IV therapy and can actually be discharged to finish IV therapy at home. But in order to do so, the patient needs to be afebrile, have negative blood cultures, and have no signs of heart failure or embolization. Anticoagulants such as Coumadin do not prevent embolization from the vegetation. These drugs are typically avoided unless they're required to prevent thrombus formation on a prosthetic valve. Finally, the patient's activities are balanced with adequate rest. Consistently use appropriate aseptic techniques to prevent the patient from contact with infective organisms. And then it's also important to continue to assess the patient for signs of heart failure, such as rapid pulse, fatigue, cough, dyspnea, and this should always be assessed throughout the antimicrobial regimen. So if any of these signs end up coming up, you should report them immediately. So if any of this does not work, the nurse should contact, or someone should contact, the cardiac surgeon, and then they'll end up having to do surgical interventions. And at this time, the 4 surgical interventions that are usually done are removing the infected valve, repairing or removing congenital shunts, repairing injured valves and chordinae tendineae, and draining the abscess of the heart. So now we're going to talk about care coordination and transition management. So community-based care for patients with infective endocarditis is essential to resolve the problem, prevent relapse, and avoid complications. If the patient is discharged to finish the IV therapy at home, the patients and families need to be willing and have the knowledge, physical ability, and resources to administer the IV antibiotics at home. You'll work with a home care nurse to complete health teaching started in the hospital and to monitor the patient for completion of their treatments. The case manager, home care nurse, and pharmacist will work together to arrange the appropriate supplies to be available at the patient's home. The patient and family should be taught how to administer the antibiotic and care for the infusion site while maintaining aseptic technique. The patient and the family should demonstrate the ability to do so before they're actually discharged. The correct timing and dosage should be emphasized to the family. The case manager should contact the patient to follow up to see if the patient is adhering to the treatment or if there's been any complications. It's important to encourage proper oral hygiene, and you should actually advise the patient to use a soft toothbrush to brush their teeth at least twice a day and to rinse the mouth with water after brushing. They should actually not use irrigation devices or to floss their teeth because bacteria may actually result. So you should actually teach them to clean any open skin areas well and apply antibiotic ointment. And in the future, you should have the patient use prophylactic antibiotics before any dental procedures. So that was overall infective endocarditis. I hope you enjoyed, and I hope you learned something good. Thanks, guys.